Good evening, sir. Kanna sir, good evening, sir. Haridas sir, good evening, sir. Raju sir, good evening, sir. Thank you for joining, sir. Uh, we warmly welcome all of you in Zoom and people who are in YouTube channel. Thank you for joining us for this important case discussion. This is our 304th, fifth session. So, Professor Haridas sir has been there with us already some time back. And thank you, sir, for kindly accepting our invitation for this case discussion today. Rakesh Sharma is from Government Stanley Medical College, kindly contributed by Professor Anandi ma'am, Professor of Surgery from Government Stanley Medical College. So, without much ado, I request the faculty to kindly take over. Rakesh, please switch on your video.
Yes, sir.
So, sit in a comfortable position. So, please introduce yourself, your unit chief, HOD ma'am, and start your presentation. Faculty, please take over. Thank you very much.
Sir, shall we start, sir?
Please, ma'am. Good luck to you.
Thank you, sir. Good evening, one of us here. Myself, Dr. Rakesh Sharma, final year General Surgery postgraduate, under the guidance of Professor Anand Unit, Government Stanley Medical College, with under the guidance of Professor S.P. Gayatri ma'am. I am presenting a case of carcinoma buccal mucosa. A 50-year-old gentleman hailing from Chennai, an auto driver by profession, belonging to lower socioeconomic status, attended OPD with complaints of in inner aspect of right cheek for the past 3 months, with the complaints of pain for the past 2 weeks. The patient was apparently normal 3 months back, after which he noticed an ulcer in the inner side of right cheek, which is insidious in onset. Started as a small ulcer in the inner right cheek, gradually progressed to attain its current size, which bleeds on touch. History of pain over the ulcer is a insidious onset. It's a dull-like type pain, progressive in nature, continuous in nature, not radiating, not referred to here, aggravated by speech and food intake, not relieved on medications. There's a excessive salivation is there. Difficulty in speech is present. Difficulty in mouth opening is there. There's a history of loss of appetite and loss of weight. There's a no history of dysphagia, no history of loss of voice, no history of hearing, no history of recent loosening of tooth, no history of trauma from sharp tooth or dentures, no history of cough with expectoration, any rise of temperature, no history of neck swelling, no history of swelling elsewhere in the body. Comorbid history. Patient is a known case of type 2 diabetes mellitus and systemic hypertension on regular treatment. There is a no history of coronary artery disease, tuberculosis, bronchial asthma, epilepsy, jaundice. Past history. There is a no history of previous ulceration, otitis discharge, or a discharge in the tongue or anywhere in the oral cavity. No history of previous surgeries in the oral cavity. No history of tooth extraction for sharp tooth. No history of ill-fitting dentures, and no history of sexually transmitted diseases. Personal history. Patient consumes a mixed diet, normal bowel, a chronic smoker for the past 20 years, smokes 4 cigarettes per day, number of packages is 4, consumes alcohol for the past 20 years, stopped since 1 year. History of tobacco usage, MAVA for the past 10 years, stopped using for the past 1 year. Then there is a history of spicy food intake is there. Family history, no history of cancer-related deaths in the family. Summary. A 58-year-old gentleman who is a chronic smoker or alcoholic with a habit of tobacco chewing, present with chief complaints of ulcer over inside of right cheek and pain over the ulcer, with a history of difficulty in speech, difficulty in mouth opening, excessive salivation, and halitosis.
Rakesh, what are the painful ulcers in the oral cavity?
Yes, sir. Yes, sir. Aphthous ulcer is there, sir. Aphthous ulcer and tuberculous ulcer is less painful, sir.
Any other ulcers which are painful?
Gummatous ulcer, sir.
Gummatous ulcer is a painful ulcer or it's a...
Gummatous ulcer. It's not a painful ulcer, sir.
And carcinomatous ulcers are painful or not?
Initially, they are not painful, sir. Painful with the secondary infection, sir.
Initially, they are usually painless, but sometimes you can get the pain in that.
Okay.
Can you go to your first slide?
Yes, sir.
Next slide. Okay. Next slide. Not radiating and not referred to the ear. What does that
Yes, sir.
mean?
There's no involvement of inner nerves, sir. There's no involvement of lingual nerve or temporoocular nerves.
What is the difference between a referred pain and a radiating pain?
Radiating pain, the pain experience along the nerve innervation, sir, and referred pain, the same.
Like in abdominal
Same
examination,
somatic regions.
there's the abdominal pain is there. Which
Yes,
pain classically is a referred pain and which pain classically is the radiating pain?
yes.
In the abdominal case, yeah.
Yes, sir. In pancreatitis, patient have a left back pain will carry to the back, sir. In pancreatitis, in conditions like pancreatitis, patient have pain carrying to back, and in
If
conditions
the
like
patient has a
cholecystitis,
cholecystitis,
yeah, patient have a pain in the right
can
shoulder.
have the referred pain or radiating pain.
It's a referred pain, sir.
And the patient has ureteric colic.
Ureteric colic patient have a groin to loin pain, sir. That's radiating pain, sir.
Okay.
Okay, can you hear me?
Yes, sir.
Dr. Haridas, okay. You said there is no speech difficulty in speech with this patient. What's the type of speech problem we expect in this patient? You said it's a buccal mucosal lesion, isn't it?
Yes, sir.
Yeah.
Patient have a restricted opening of mouth, sir. Patient having trismus, sir. They is unable to open the mouth properly.
Okay.
Patient
So
have
when will the patient get a problem with speech? What problem? What is the mechanism of difficulty in speech in case of oral cancer? Usually. Yeah, trismus, extreme trismus, maybe patient will have some problem. Okay, so I agree. Extreme trismus. Yeah. What are the common problems you associate with the difficulty in speech?
Intrinsic muscle involvement, sir.
Yeah, it's more in tongue problem, isn't it? More than the tongue problem. Yeah, mobility of the tongue. Yeah, when the mobility of the tongue is restricted, patient may have some problem in articulating the speech, isn't it? Okay, that's one.
Yes.
Then hoarseness voice, he said. Why? What is the reason you asked for the hoarseness of voice? He said there is no hoarseness of voice in this patient. What is the reason?
Hoarseness of voice. This patient not having any hoarseness, sir.
Yeah, why did you look for that? Is there any reason for specifically looking for hoarseness of voice in this patient?
Yes, sir. There is a posterior pharyngeal involvement in oropharynx carcinomas. There will be hoarseness of voice.
No, do you think this is you said as a lesion is in the buccal mucosa, is visible part of the oral cavity, oral pharyngeal carcinoma? Is it an oral pharyngeal lesion?
No, sir.
Okay. You can probably explain by saying there's something like field cancerization. That's what maybe you wanted to say, isn't it? Oral cavity, you can have field cancerization. Maybe second malignancy you expect in the oral pharynx area, larynx.
Maybe,
Apart from that, there is no point in saying there is a hoarseness. You don't expect hoarseness in case of oral malignancy, isn't it? So you should be careful when you're presenting a case because unnecessary things you should avoid. Okay, there's no relation with hoarseness and oral cavity malignancy. Then you said cough. What is there any relation with cough? Whatever you say in the history, we'll be asking about that only. What is the problem with what can you expect cough in this patient? Recurrent cough.
Is there a patient having any lung meds? Patient might have cough, sir.
Okay. Any other reason?
That is yes, sir. There is a involvement of posterior one third of tongue. There will be a loss of gag reflex.
Yeah, recurrent aspiration, oral cavity, mobility of tongue is restricted. Recurrent aspirations can occur. Recurrent pneumonitis or bronchitis can happen. Patient may have chronic cough. Oral metastatic lesions. Okay, so these are the reasons. Whatever you say in the history, you should be able to explain. What is that?
Sure.
Why did you ask about? Okay. Now, tobacco chewing. What type of tobacco chewing is more important? Have you heard of quid? What is quid? What is Indian oral cancer? Have you heard of that? Indian oral cancer. Yeah. What is it?
Gingivobuccal cancer, sir.
Yes.
Is a
What is the
common-
reason?
Yes, sir. And there's a habit of using quid, sir. Quid is a mixing of betel nut along with areca nut and smoked lime kept in the gingivobuccal sulcus overnight.
Yes.
It causes continuous irritation, which leads to the cancer.
Yeah.
Yes.
The most common reason area is the gingivobuccal sulcus, and as you correctly mentioned, it's quid. It's just a preparation is called quid, isn't it? So that is one of the common reasons.
Yes, sir.
So referred pain, you sir asked about referred pain. What is the reason for referred pain in oral cavity malignancy, which is referred to the ear? What is the reason? Can you explain what is the reason?
Yes, sir. In advanced cases, there will be involvement of lingual nerve, which shows a common sensory innervation to the temporoauricular nerves. So the patient will have pain in the ears.
Yeah, correct. Both of them are divisions of the mandibular division of the trigeminal nerve. So the common the nucleus will be in trigeminal nucleus. From there, it may be referred to through the auriculotemporal nerve, which innervates the ear. It can be referred to that, isn't it? That is the anterior 1/3, anterior 2/3. Posterior 1/3 is there a different reason is there because the common innervation with the glossopharyngeal nerve. Okay, so the pain can be referred to the ear. So that's the referred pain you can usually see in case of a oral malignancy. So you should be able to explain and yeah, continue with your history and examination. Yeah,
Thanks. From the general examination, patient is conscious oriented, moderately built, moderately nourished. I come to the ECOG status of 1. No pallor, no stress, no cyanosis, no pedal edema, no clubbing. There is no generation lipodinopathy. Adequate hydration, halitosis present, and there is a ruling of saliva from the right angle. On the vital signs, pulse rate is 76 per minute, regular rhythm, normal volume, and palpated equally in all peripheral palpable cells. BP is 130/80, measured in left upper arm in sitting posture. The respiratory rate is 18 per minute, abdominal thoracic respiration, and patient was AF bed. In the examination of oral cavity, inspection, there is a ulcerapalpatic growth of size, 4x3 cm noted over the right buccal mucosa, which is extending anteriorly about 1 cm from the angle of mouth and posteriorly up to the level of retromolar trigone, superiorly about 2 cm from the articulate buccal sulcus, and inferiorly about 1 cm from the lower gingivobuccal sulcus. It's irregular in shape, margins are ill-defined, edges are everted, and there is another ulcerapalpatic growth of size, 2x1 cm noted over the mucosal surface of the lower lip, and surrounding edema area were edematous. Mouth opening restricted, admits only 1 finger. Tongue are normal, mobility is normal, able to publish the tongue. There is no fissures seen in the tongue. Gums alveoli were normal. Nicotine stain of tooth is present. Second premolar of lower jaw is having a dental caries, and sharp tooth is present adjacent to the ulcer. Flora of the mouth appears normal. Hard and soft palate were hyperpigmented. Anterior and posterior pillars are normal. Uvula is in midline. No tonsillar enlargement, and posterior pharyngeal wall is normal. This is the clinical picture, which shows ulcerapalpatic growth in the lower lip, and this patient have a difficulty in mouth opening. The area of ulcer could not be exposed properly, and you can see the anterior border of the ulcer. Palpation, tenderness present over the ulcer margins. Inspectory findings of size, shape, and extent were confirmed. Innervation is present at the base of ulcer, about 0.5 cm from the edge, and is bleeds on touch. No mandibular thickening or irregularities noted on the bidigital palpation. And examination of neck nodes, a node of size 2x1 cm palpable in level 1B, right side, which is tender, mobile in nature, and firm in consistency. Other system examinations are normal. Some who's a chronic smoker and alcoholic, a habit of tobacco chewing presented with chief prominence of ulcer over right inner side of right cheek and pain over the ulcer with a history of difficulty in speech, difficulty in mouth opening, excessive salivation, and halitosis. On examination, the ulcer of size 4 plus 3 cm is present in the right buccal mucosa with innervation with palpable tender right 1B level lymph node.
Okay. So, what was the size of the 4 inch 3 centimeter size, isn't it?
Yes, 4 plus 3 centimeters.
Oh, okay. It is in the buccal mucosa extending to the lip, is it? Or both
Yes,
are the separate lesions?
both are separate, sir. Both are separate.
Okay, patient is a chronic
Alcoholic.
fever and alcoholic. Okay, fine.
Yes, sir.
And this, what is trismus? He said trismus. What is the level of trismus here? Grade of the trismus?
Grade 3, sir. Admit only one finger, sir.
That means less than
Less than 1.5 centimeters.
less than 1.5 centimeters. Very serious. What is the reason for trismus in this case? Probably.
Might be a chronic usage of tobacco. Patient may have submucosal fibrosis, sir.
With this large lesion, you would like to attribute it to submucous fibrosis or something?
No, sir, it might be involvement of buccinata space and pterygoid space also, sir. So that might be the reason for.
Okay, before saying that, what is the clinical diagnosis? We didn't ask about the clinical diagnosis. What is the clinical diagnosis?
Clinical diagnosis, carcinoma of buccal mucosa.
Yes, there is no other diagnosis in this case. There is no need for any differential diagnosis. So obviously, large ulcer proliferative everted edges and all you said. Large lesion. Okay. So the trismus reason is what?
Sir,
What is the reason for trismus, you said?
trismus is an invasion of the ulcer, invasion of the carcinoma to the pterygoid plates and buccinal space. And temporomandibular joint, sir.
Temporomandibular joint. Is it involving the temporomandibular joint?
No, sir.
Be careful when you say.
Okay, sir.
It is usually, I agree with the pterygoid space and the
Buccinal.
pterygoid muscle, the pterygoid space, the buccinator and pterygoid muscles could be infiltrated. That's the reason. Okay, because the ulcer is very close to that region. You said this is very close to the retromandibular trigon and also maybe infiltrated. Okay, so you can have the trismus in this case. Were you able to examine the posterior extent of the ulcer? Were you able to see the posterior extent of the ulcer?
So with much difficulty able to see the extent, sir. With the palpation, I can feel the extent.
So is it extending to the retromolar? What is the retromolar trigon?
It's a triangular space with a border of ascending ramus of the mandible and with the upper margin behind the upper third molar and lower margin with behind the lower third molar space.
Okay, what is the importance of that space, retromolar trigon?
Any invasion in the retromolar trigon invades the skull base of the skull, sir, and there'll be eroding in maxilla.
Yeah, it's a very the area very close to the base of skull and what you mentioned, masticator space and all this becomes once that space is infiltrated, practically this malignancy may become inoperable, isn't it? So very advanced disease. So that's an area. So you have to examine the posterior limit very carefully here because that will determine how far it is going. Okay. So you were not able to visualize that area because of the trismus. Patient is not able to open the mouth properly. Okay. What is the reason for two separate lesions now? You said both are two separate lesions. You said there is a space of normal tissue in between, normal mucosa in between the two lesions, isn't it?
Some intonation will be there, sir.
So it's not part of a single lesion, it's two separate lesions.
Yes, sir.
So here comes the question of field cancerization. What do you mean by field cancerization?
Diffuse field cancerization is the diffuse exposure of risk factors causing multiple primary lesions in the oral cavities.
Yeah, in case of oral cavity, which are the areas you will have to be carefully looking into where we can have field cancerization?
Cancerization.
The other areas of oral cavity, as well as the upper aerodigestive tract. You can have in the upper aerodigestive, all over upper aerodigestive tract. Okay,
Okay, sir.
the pharynx, hypopharynx, even esophagus. So you have to think it in your keep it in your mind that because patients have multiple lesions, can have multiple other lesions as well.
Okay.
So that may
Which
explain
lesion
your.
has come first? The
Sir?
buccal mucosa or the lip lesion? Which lesion has come first? You're telling the two lesions, no? One in the
Yes, sir.
buccal mucosa, another in the lip.
Buccal mucosa came first, sir.
And after how much time the lip lesion came?
Yeah. Last 1 month, sir. Patient having the patient for the past 1 month.
I think in your patient, so much of the trismus is there, it will be really difficult to examine, as Dr. Haridas saying that it will be difficult to examine the oral cavity as such of the posterior side.
Yes.
Could you see any pre-malignant lesions in the oral cavity in your patient?
No, sir. There is no other primary lesion, sir.
What pre-malignant lesions you have looked for?
Leukoplakia, erythroplakia, sir.
So which leukoplakia is really pre-malignant? All the leukoplakias are pre-malignant?
No, sir. Nodular or spical leukoplakia.
Okay. Apart from this variety, what are the other risk factors in the leukoplakia?
Yes, sir.
According to location,
Yes, sir. Floor of the mouth. The
tongue
patient
and
having leukoplakia floor of the mouth is more highly risk for carcinomas.
size of the leukoplakia.
Size.
Yes. Type of the leukoplakia. Yeah.
See, nowadays the terminology, what is the new terminology for the pre-malignant lesion? Before we used the pre-malignant lesion and pre-malignant conditions. There was old Bailey, if you see. There are two terminologies, pre-malignant lesions and pre-malignant conditions. Nowadays the terminology they have incorporated in one, pre-malignant disorders. It's called pre-malignant disorders. Okay. What are the most common pre-malignant disorders of the oral cavity?
Oral candidiasis.
Oral candidiasis, we mentioned already, erythroplakia. The most common is erythroplakia. Okay, so it's got a very high chance of malignancy compared to leukoplakia, erythroplakia or erythroleukoplakia. There may be mixed erythroleukoplakia. There may be lichen planus. Okay, oral submucous fibrosis. All these are pre-malignant disorders of the oral cavity. Okay, all may be related to smoking as well as the tobacco chewing. All these are pre-malignant disorders of the oral cavity. Okay, so you have to carefully look for. One thing is examination is not complete until you see the entire oral cavity, entire upper aerodigestive tract. You have to examine, not maybe either by clinically or some other means. You have to use some scopy and other things to see. All my oral cavity, you have to see the effect of field cancerization. Then only the examination is complete. Okay. Without that, you can't say it is okay. So sometimes maybe multiple lesions will be there. So after that only you will come to a probable diagnosis of this. Neck, what is the neck finding? Single node.
Yes, sir. Only one single node is of level 2B, sir. 2 × 1 centimeter, which is
level 1B. 1B or 2B?
1B, sir.
1B.
Yes, sir.
Okay, level 1B node is there. Right. So drooling of saliva, can you explain what is the reason for drooling of saliva in this case? There is a drooling.
Yes, sir. There will be a pooling of saliva in the mouth. Patient will not able to swallow the saliva. And another thing is there will be a involvement of nerve fibers. Sensory nerve fibers might be get involved. So patient cannot able to swallow.
No, all these are not very common with buccal mucosa. These are all common with tongue malignancy. You can have the mobility of tongue is restricted. You can have drooling. You can have difficulty in swallowing, aspiration, dysarthria. All these are very common with okay. But with advanced malignancy, you can expect all this because of the Christmas and all this. We can explain. I'm asking because I'm looking whether you are explaining it. There may be an explanation. You should be able to explain it, right? Okay. Now, what is the clinical diagnosis? Carcinoma or buccal mucosa? Okay. Clinical staging. What is the clinical stage?
Clinical T3N1, sir.
T3N1. Okay. So before we go into the management, all those things, can you describe the oral cavity areas? What are the oral cavity areas will you describe? How will you describe the oral cavity? Various areas of the oral cavity.
Yes. Oral cavity area from the vermiform border of the lip, buccal mucosa, vestibule, floor of the mouth, tongue, hard palate, upper and lower gingivobuccal sulcus, and retromolar trigones.
Okay, so I hope you know the various boundaries and of all this. Okay, only because one area lesion can extend to another area in oral cavity. So predominant area and you should describe, and which is extending to another area you should describe. That's how you should describe. Okay. For example, tongue malignancy can extend to the floor of the mouth. Reverse can also happen. A floor of the mouth can extend to this. So you have to be explaining it properly, which area is predominant lesion, where is the predominant lesion, and where it is extending it to. That's how you should describe. In this case, my question is two questions. One is it extending into the retromolar trigone, which you can't see, obviously. Is it extending into the alveolar margin?
No, sir. There is some space between the alveolar margins, sir.
So it's not involving alveolar margin. But the lower lip lesion which you showed, I think is very close to the alveolar margin. Can you show the picture of the lip lesion?
Sure, sir.
Yeah, here it is very close to the, I don't know, we can't appreciate whether there's a space between the ulcer and the gingival margin, isn't it?
Yes, sir.
Is there a margin there?
Yes, sir, there is some margins there, sir. Only some infiltration is there, sir.
So there is a doubtful infiltration, isn't it?
Okay.
So that's why it's very important because that will change the management of this patient. The approach to the patient management will change. You should commit whether it's infiltrating the gingival margin or the gingival margin could not be made out. Is it infiltrating or not infiltrating? It will make a lot of difference to the final management of this patient.
Okay.
Okay.
Is your lesion fixed to the skin or not? Did you check for that?
Yes, sir. Lesion not fixed to the skin, sir.
You are able to you are able to pinch the skin over that?
Yes, sir.
Okay.
Skin is not involved.
It is not fixed to the mandible also?
Not fixed to the mandible, sir.
Okay.
To continue with that, is there any parotid swelling in this patient?
No, sir. No parotid.
Can you expect a parotid swelling in this patient?
Yes, sir.
What is the reason?
Locally advanced lesion, there will be a lymph node spread. I mean, there will be
what? I didn't hear you. What?
In a locally advanced lesion, sir, there is a lymphatic spread.
No. Where is the duct opening? Parotid duct opening?
Yes, sir. It is opening begin the third molar, sir. So
third molar. Complete your sentence.
Parotid duct open begin the third upper molar, sir.
No, it is opening at the buccal.
Second. Yeah, it's the second molar. Yeah.
Second molar.
You have to clearly mention it's upper. It opens at the buccal mucosa opposite upper second molar tooth. Okay. So your ulcer is almost in the same location, isn't it? So is there any chance that the parotid duct will be infiltrated by this lesion?
No, sir. It won't infiltrate, sir.
Why? It isn't the same lesion area you described the buccal area.
Because there's a continuous drainage of saliva from the parotid gland, duct will be spared, sir.
Duct is spared or duct will be spared? What is the answer? What did you say?
Since there is a continuous draining of saliva from the duct, it won't get involved, sir.
It can be blocked, it can be blocked because of the tumor. And that is why there may be parotitis may be there.
Yes. You have to see this area is the opening of the parotid duct. So it can be infiltrated by the tumor and it can be blocked by the tumor, as sir mentioned. Okay. And secondary to that, there could be a parotitis, distension of the parotid gland, parotitis. So you have to see that. Is there any swelling in the parotid or that side? Right.
No, no, sir. There's no swelling over the parotid.
You have to mention that also.
Okay, sir.
Okay. Okay. Right, sir. We will go into
What-
the management, sir.
Yeah,
Other side.
did you ask about the history of the human papilloma virus here?
Yes, sir. I asked, sir.
So how the human papilloma virus related cancers are different from the non-human papilloma virus cancers?
In human papilloma virus related carcinoma, there is a low risk of low exposure of risk factors. So it will have good prognosis with chemo and radiotherapy.
Who are younger? Human papilloma
Yes, sir.
virus?
In
Or-
younger patients.
Okay. Advanced stage, more common in human papilloma, or
Sir?
they are more advanced, but prognosis somehow is good.
Yes, sir.
Okay. And where are they usually located? That's the most important thing. Where are the HPV related cancers? are related?
Malignancy.
Yeah.
Most common site of HPV related malignancy. That's correct.
Oropharynx, sir. There is no oropharynx, sir. That is the most common site of
Yeah.
HPV related.
Yeah. Is there any other virus involved in the oral or other any malignancy? Not in oral malignancy, some related to oral nasopharyngeal. I'll give you a clue. Nasopharyngeal malignancy.
Epstein-Barr virus.
Yeah, very good. Epstein-Barr virus. SPV is more commonly associated with oropharynx, not in exactly oropharynx. It's got a better prognosis compared to any younger patients. Okay. Right.
Which strain is there for the HPV? There are so many strains are there. So which
sir.
strain is more common?
16, sir.
16.
16.
16 and 18. जो है
18.
ना?
Yeah.
Okay.
Fine. So you have to ask about the sexual habits of the patient and then the contacts and all those. Okay. Papilloma virus. Okay, correct.
Okay, sir.
So that's the situation. Man, 60-year-old, 58-year-old man with a large ulcer, two ulcers, with a trismus, malignant looking ulcers, edema of the cheek. It is now. What is the thickness of the cheek? Did you examine the cheek thickness? Is it did you feel the cheek is infiltrated or is only the mucosa ulcer?
Sir, the outer side of the cheek skin is normal only, sir. Not individual or not edematous.
Now, skin is normal, already you mentioned. But what about the muscles of the cheek, that the buccinator and all the muscles? Is it the thickness of the cheek is normal with the opposite side? Do you feel the muscles are infiltrated?
Somehow thickened, sir. The muscles are thickened, sir.
Muscle infiltration, buccinator and all the muscles could be infiltrated. Is it?
Yes, sir.
Okay. So that is the situation. Okay, with this ulcer, what will you do?
First, I will confirm my diagnosis, sir, by taking a age-use biopsy from the primary ulcer, sir.
Okay.
And then, if possible, take a ultrasound guided lymph node FNAC, sir.
Why you want ultrasound guided biopsy here? If it's 1.5 centimeter, you know.
Normal FNAC, sir.
What way ultrasound will help you?
There is it tells about the hilum of the lymph nodes, sir. There is a hilum is preserved or
What are the, in other words, you tell me what are the features of a probable malignancy with ultrasound on its lymph node?
lymph node will be rounded, sir. There will be a loss of fatty hilum, sir.
Yeah. It could be, it will be more rounded, more than, this is a 1B node, no? Submandibular lymph node. What is the significant size of the submandibular node where you take it as significant size? Submandibular region is actually 1.5 centimeter. All other neck regions 1 centimeter. Retropharyngeal node is actually 0.8 centimeter. That's what the cutoff value. It could be vary this way or that way. Right.
Okay.
So it's a 1.5 centimeter significant size. It could be rounded, maybe rounded, lot of platyhylum, peripheral hypervascularity,
Okay, sir.
peripheral hypervascularity, cystic spaces. That's very important. Nodes maybe have cystic areas. Cystic nodes are more significant. Okay, cystic changes inside the node is a significant. Okay, so this way it may help you in ultrasound guidance. Otherwise, obviously large node you can take multiple FNAs even without guidance. Okay, so large, very large node, yeah, you can strike
Rakesh, when you
areas
are
of
doing the
non-network.
ultrasound, you know what is the frequency of the probe which is used for the neck ultrasound? What is the frequency of the probe for the neck ultrasound? When you do the abdominal ultrasound, what is the frequency which is used?
High frequency, sir. Usually we use it for abdomen, and we use low frequency superficial stretches, sir.
Rakesh?
We're not able to listen, hear you. Talk loud.
Sorry, sir. We use the high frequency ultrasound for abdominal structures, sir. Since there is a thick fat, thick anti-abdominal wall, we will use low frequency probes for superficial sectors, sir.
So when you're doing the abdominal ultrasound, you know what is the frequency which is used?
Okay, sir.
Okay. It is 3.5
No,
to
sir.
5 megahertz. Okay.
Okay, sir. Okay,
Right.
sir.
So when you are doing it for the superficial structures which are there, like thyroid, breast, neck, no, you use about 7.5 to 10 or even more than 10 megahertz here.
Okay, sir.
When you do the endo ultrasound, you know what is the frequency which is used?
Sir, couldn't get you, sir.
Endo USD, endo ultrasound. What is
It's
that?
even
Endo
higher. It's even higher, up to 15 megahertz here.
Okay, sir.
Okay. So the basic is that higher the frequency is there, better is the
Lower the-
resolution and lesser the penetration there. Okay.
Sure.
Okay.
Okay, Rakesh. Now you have taken a biopsy. You have taken an FNAC, isn't it? So biopsy is as a squamous cell carcinoma, well different or moderately differentiated or poorly differentiated, and the FNAC is showing metastasis from squamous cell carcinoma. What else do you look for in ultrasound? Only you take for biopsy, or anything else you look for in ultrasound? Next.
Sir, couldn't get you, sir.
What else you look for with ultrasound? You will only use it for taking FNAC, or anything else you look for in the neck?
Look for any extranodal extensions.
Okay. What are the features of extranodal extension by ultrasound? When you say there is extranodal extension, clinically, radiologically, actually extranodal extension is a pathological terminology, but clinically and radiologically you can get suggestions about ENE. What are the suggestions? Yeah, it can be a fixed node clinically, extending to skin, maybe nerve infiltration, nerve palsies, vascular encasement, fixity to the deeper structures like prevertebral fascia muscles, all this. All this can be seen with ultrasound also. Or matting of the nodes. 2 nodes, 3 nodes are clumped together. That's also a feature of a ENE. Maybe 2, 3 nodes are stuck together. This may be due to ENE. Okay. So this clue you will get. Anything else you look for with ultrasound? Will you look for other nodes in the neck? Or will you concentrate only on the palpable node only? Why don't you look for other nodes in the neck?
Huh? Opposite of the
node opposite, same side. There's only one B. The level 2, 3 nodes can be infiltrated, involved. Level 5 maybe not palpable. Okay.
Okay, sir.
Opposite side of the neck you should see. It could be bilateral.
Okay.
Which are the areas of oral cavity you may get bilateral node representation?
In tongue carcinoma, sir.
All areas of tongue?
No, sir. Anterior 1/3, sir.
No. Tip of the tongue maybe, floor of the mouth, posterior 1/3. Basically, the posterior 1/3 of the tongue. and the lower lips. There is a decussation of the lymphatics. From one side, it can go to the other side. So you may get bilateral nodes. So here is the buccal mucosa and lip is involved. Yes, you may get bilateral nodes also. Lower lip is already okay. So you have to see the other side also, clinically as well as with the radiology. Since you are using a high frequency ultrasound, as sir mentioned, you can always look for other nodes. Not only for taking FNAC, you should see that will change the staging pattern, isn't it? Staging will be changed. The management will change accordingly. So always use that. Once you're using an ultrasound, why don't you see the other areas or the neck as well? Okay. So you can also see the submandibular gland also. Sometimes gland may be infiltrated because the gland node is sitting there only. Right. All those things you can see. Okay. With this FNAC, what are you going to do? It is a secondaries from
Next,
commercial carcinoma.
sir.
It's a commercial carcinoma with secondaries in the node.
Okay, sir. Next, we'll take a contrast against enhanced CT, sir, to look for other nodal involvement and vessel status and bone involvement, sir.
Contrast and enhanced CT of which region? Neck only or neck?
Neck, sir.
I mean, you don't want to primary lesion. What do you do? You don't want to do it.
Head and neck, face and neck, sir.
Okay, what all things you look for in CT? CCT.
CCT, I look for
many of the things you are not able to examine clinically, in this
Yeah,
case.
yeah.
So you have to see for the retromotor trigone, you have to see for the mandibular involvement, all those things. So CT is a must in this patient. Okay. Apart from the staging part, you have to exactly know on the CT scan. Yeah.
The tumor is very close to the alveolar margin. We don't know the mandible is infiltrated. Retromandibular trigone is you should see. The tumor thickness, you have to see whether it's infiltrated the muscles of your buccal mucosa. Okay? Masticator space, masticator muscle. All those muscles you have to see. The second lesion is in the lower lip region, which is very close to the mandible and alveolar margin, whether it's infiltrating the cortex, on periosteum, cortex, or cortical bone. All these are important. How far it has gone into the bone is very important. Again, we'll be having a lot of bearing on the management. Okay. The CT scan of the region is very, very important because we are not able to see examination was compromised. The CT may give you a better view of the muscles and the bone, especially the bone of the mandible and all this. Okay. Any reason to do MRI?
For soft tissue extension, we are doing MRI, sir, especially in tongue carcinoma, person with MRI.
Yeah, tongue maybe yes, the MRI may be involved. But in this case, probably if you want to see the parotids and infiltration parotid duct and space involvement, MRI may help you there. But CT is also equally good. Once since you stick with one investigation, that's okay. CT scan also is almost same result you'll get. Okay, no need to do two investigations. Sometimes you may need to do two investigations to see better muscle involvement, especially tongue, whether involvement of extra extrinsic muscles and the other spaces of in the tongue. You may have to do an MRI better. Okay, but the buccal mucosa CT will be equally good. It will give you the infiltration as well as the bone infiltration, extend everything you will get with CT. Okay, so CT will give you a better clue. Suppose it's infiltrating the anything, sir? You want to add something, sir? Ajay, sir?
Yeah. Now, if you have to choose between the CT and MRI in this patient, which one you will go for that? Yeah. But definitely the CT scan in this patient, because MRI is mainly for MRI mainly for the tongue and the floor of the mouth, you go for that. But once the cheek lesion is there, you have to see whether that vestibule is getting involved in that, whether alveolus is getting involved or not, whether mandible is getting involved or not. So the CT will be a better option. So you have to choose between these two. Probably the CT will be the choice in this patient. Okay.
Okay, sir.
Okay. Now, suppose now CT scan is telling you it's infiltrating the alveolar margin. Periosteum is involved by the. Okay. Is there any role for any X-rays? Will you consider OPG X-rays in this case? What is the problem with the OPG CT for involvement of the bone?
You can proceed with
No. If you don't get confused, if there is a CT, that's the best. Okay, no need for consider OPG. OPG will give you a positive result only if the bone is infiltrated up to maybe up to 30% infiltration. Okay, early infiltration you will not be picked up by OPG. CT is much better. Since we are doing CT, that's enough. There's no need to consider OPG in this. Okay. So what do you do? Suppose there's a bone very close to the bone, periosteum is involved with this bone, and what will you do? So you have to do what? Any other staging investigation you would like to do? Only neck you would like to finish with the neck?
No, sir, you have to look for any metastatic workup, sir.
Hmm.
The chest will be taken, sir. It can be taken, sir. Ultrasound abdomen will be taken, sir.
Okay. Any other investigation you would like to do for examination? You already mentioned in the initial part. The history part we have already touched upon. No, you have to examine the other upper aerodigestive tract area also. Never miss it out. Okay, all oral malignancy, especially such an extensive lesion like this. So you have to examine the upper aerodigestive tract, maybe by Scopes. Maybe you can get to the ENT examination of the ENT area, and upper OGD Scopes to see the upper esophagus and all. Okay, that's also part of the evaluation, especially in multiple lesions and extensive lesion like this. Don't forget to mention that.
Okay, sir.
Okay.
Where do they metastasize? Distant metastasis, where do you get that?
Lungs and bones, sir. Lungs and bones, sir.
Lungs and bones. Okay. So why you are doing the ultrasound of the abdomen? Any reason for that? No, you may get it for that, but otherwise, hardly metastasis to the liver or any other organ there.
Yes.
So it's mainly the lungs you have to see for that. That is the main site which can be there, the distant metastasis as well. And all the Scopes has to be done, you have to see, because there are two lesions in your patient which are obvious. So you have to look for any other synchronous lesion in this. So you have to carry out definitely the Scopes here. Okay.
Suppose the malignancy, what will be the clinical TNM staging? What can you tell what is the clinical TNM staging?
Clinical TNM staging is T3N1, sir.
What is T3?
T3 having a tumor of size more than 4 centimeters. The extranodal invasion of.
Okay, that's the one thing. More than 4 centimeters. Now, what the latest TNM? I think the latest 9th edition has just come. There is a very big importance to the tumor depth of invasion to the tumor. Have you heard of depth of invasion? What is the depth of invasion? What do you mean by depth of invasion? What is tumor thickness? There are two terminologies you should be worried about, or you should be knowing. Tumor thickness and depth of invasion. Both are same or not? See, tumor thickness is the thickness of the whole tumor from the surface to the depth. That's very simple, isn't it? Tumor thickness. The depth of invasion is the invasion of the tumor beyond the basement membrane. How much basement membrane? If it is flat lesion, this could be both are same, flat. In a protruded lesion, which will be more? Tumor thickness will be more than the. Can there be a situation where the tumor thickness will be less than the depth of invasion? Depth of invasion, can it be more than the tumor thickness in any type of tumors? Can you think about and say? In an ulcerated lesion, simple ulcerated lesion, there is no tumor thickness. Tumor thickness will be less than the depth of invasion.
Okay.
So in the latest TNM, there is a lot of importance to depth of invasion. Okay. So depth of invasion can upstage or downstage a tumor.
Yes,
You
sir.
mentioned is correct, to more than 4 centimeter with the depth of invasion less than 10 mm is considered as T3. Okay, less than 4 mm, more than 4 mm with depth of invasion is more than 10 mm, it will be T4A. Understand?
Yes, sir.
So depth of invasion, that also you have to add. Depth of invasion has a very important role. Similarly, a T1 lesion, tumor less than 2 centimeter with the depth of invasion less than 5 mm is considered as T1. Same less than 2 centimeter lesion, if the depth of invasion is more than 5 but less than 10 mm, it is T2. Understand?
Okay.
So that's a change is coming in the latest 9th edition that you should know. So in this case, it's obviously more than 4 centimeter. So I think it is a. So these are two primary lesions, or one of them is it a metastatic lesion? Primary with metastasis, local metastasis, or both are primary lesions? There are some criteria, no? What are the, you know that?
As a synchronous and metastasis. If the primary lesion occurs within it might be a metastasis. There will be a less chance of a synchronous lesion.
Okay. No, there is something called second primary or second primary lesion or metastatic. Maybe one of them is a metastasis from the primary, or both of them appear at the same time, almost same time, isn't it?
Yes, sir.
Okay, so maybe both of them are same primary lesion only, so not a metastatic lesion. What do you think?
Sir?
Both are primary lesion, or one of them is a metastasis from the other lesion? That's the question.
Rakesh, how do you define a synchronous lesion and a metachronous lesion?
Yeah. Any primary lesion,
Okay.
any lesion occurs within 6 months of the primary lesion, it's a synchronous lesion, sir. And if there is any other primary lesion, any other lesion occurs after 6 months of the primary lesion, it's called metastatic lesions.
So is it in the same region you call it as, or it can be anywhere?
In the same areas.
It can occur anywhere, actually.
Okay.
Okay, so if somebody has got a oral cancer and you find a cervical cancer, then that is also considered as a metachronous synchronous lesion. Okay.
Okay.
So it can occur in any area. Okay.
Okay. So what will you do with this finding? There is no distant metastasis. It is infiltrating a lesion, extending right up to the premolar trigone, but not infiltrating the premolar trigone, but infiltrating the mandible. Trismus, multiple, two large lesions in the oral. Almost the left half or right half of the whole cheek is involved. T3. Why do you say T3? Is it not? It is not T4A. What is T4A?
Sorry, sir.
Say a lesion more than 4 centimeter with a depth of invasion more than 10 mm.
Okay, sir.
It is T4A. Also, it is involving the skin, muscles, periosteum of the bone is a T4A. So here there is every chance that it is a T4A lesion, not a T3 lesion.
Okay, sir.
Okay, so no, the T3 staging is not correct. Clinically, it looks like a T4A lesion. What is T4B lesion?
T4 deletion involving the base of skull and dedicate space by
Yeah.
oxygen.
Okay. T4B is an inoperable lesion, isn't it? Primarily, it is not operable because base of skull or encasement of the internal carotid artery more than 270 degree, prevertebral fascia, if it is a neck lesion. So all these are inoperable. So it doesn't look like a that, but you have to be again careful about the retromolar trigon. If the retromolar trigon is infiltrated, then it becomes a T4B lesion also.
Okay.
It is never, it's not a T3 lesion. Okay. T4A definitely, T4B has to be confirmed by the presence or absence of the involvement of the retromolar trigon and beyond, base of skull and all. Okay. Because patient is having severe trismus, so every time it could even be a T4B lesion.
Okay, sir.
Okay, so don't say T4, T3 lesion, not T3.
Okay.
Okay, now T3 and 1 lesion, isn't it?
These are T3 and 1.
Are you sure is N1 lesion? Suppose there is extranodal extension. What is that N status? That's the only pathologically, or your ultrasound, you see 2-3 nodes are stuck together. What will be the N status?
External mention N2, sir.
N3B. Okay. So whatever may be the size of the lymph node, don't go by the size only. Finally, the N status is determined by the extranodal extension. Okay. It is basically pathologically, but clinically, if the obvious extension seen, it is clinically N3B. So here again, N can be is also variable. And though only one single node you palpate, maybe the further evaluation or even pathological evaluation we find is that extranodal extension, then status will change from N1 to N3B, whatever may be the size of the lymph. Okay.
Okay.
So no obvious metastasis M1. So T4A or B bar N1 bar N3B, that is the current staging. Clinically N1, but pending the evaluation, pathological evaluation will change. But this you should know, not only based on the size alone, right? Okay. So what will you do with this patient now? With this patient?
So, multimodal is the first confirm the diagnosis, sir. And if it's a T4, it's an advanced stage, first patient go with chemo and radiations, chemotherapy and
Chemo and radiation, you say.
no, sir. Radiotherapy, sir. First, the patient
Radiotherapy. Any problem with radiation therapy you can expect in this patient?
Yes, sir. If the patient, if the lesion is closely adherent to the bone structures, there will be radiosteonecrosis will be there, sir.
Before that, what are the operable lesions?
Must be discussed in the MDT, okay? There is no doubt that you have to discuss this particular patient to tell that what exact treatment this patient is going with. You have to discuss the multidisciplinary group here. Okay, and then based on that, you have to decide. So
it's not a straightforward case, it's a very complicated case, as sir mentioned. It's not a very, you can do this like that. It's a very advanced case, right? So what are the operable lesions in oral cavity lesion malignancy where you can operate upfront?
Yes, sir.
By and large, I mean, generally speaking.
Operable lesions, T1, sir. T1
Anything? No, not T1. Even up to T1 to T4A, N1 to N3 is operable, provided there is no extra nodal extension. Okay, T1 to T4A or N1 to N3 without metastasis, M0 obviously. Okay, they are operable provided patient's performance status is good, no extra nodal extension. It's operable. What are the inoperable conditions where a patient cannot be operated upfront because of the advance? What are the conditions where you think about that? Inoperable lesion. Hello, Rakesh. Can you hear?
Yes, sir. Can you hear me, sir? Yes, sir. And that's, sir, if the lesion encasing the internal carotid artery.
T4B, yeah.
if you took
T4B, yeah. That's T4B, yes. T4B lesion, yes. Anything else? Metastatic lesion, M0, yes. You don't go upfront surgery. Then performance status of the patient is not good. You know, patient is having an early lesion, but patient hardly can breathe, have a severe heart disease. This nowadays, latest management of all malignancy, you have to consider this. You know, changing. You can't don't just jump and say in the exam that I will do this, and the patient hardly can breathe. Patient's cardiac condition is very poor. So performance status and local conditions like T4B or metastatic lesion, you don't consider. These are inoperable conditions. Anything from T14A.
Does your patient have any comorbid conditions today? Does your patient
Yes,
has
sir.
got
Patient
any
is
comorbid condition?
diabetic and hypertensive. Yes, the patient is diabetic and hypertensive.
Is your patient having diabetic?
Yes, the patient is diabetic and hypertensive.
Oh, hypertensive also. Okay.
Yes, sir.
No cardiac problems?
No cardiac problems, sir.
Okay. So why can't you go for a surgery in this patient directly? What is the reason that you cannot go for a primary surgery in this patient? Are you there, Rakesh?
Can you hear me, sir?
I think your connection is little.
Yes,
sir.
sir. Yes, sir.
It's raining here, sir. Sorry, sir.
He's back, sir.
Sir?
No, I was asking you that why we cannot go for the primary surgery in this patient. The reason for that. Yeah.
First, we have to evaluate the patients regarding the advancement of the lesions. If there is an involvement of base of skull, or the patient having a T4B, we can go for the surgery.
No, the biggest problem in this patient is the patient is having that severe trismus.
Okay, sir.
You have to find out the cause for that particular trismus.
Okay,
Is the pterygoids are getting involved in that? Or is the retromotor trigone is getting involved in that?
okay, sir.
So you have to find out. Otherwise, this type of the lesion which is there, which is in the buccal mucosa and the lip lesion is there in continuity, you can go for the direct surgery in this patient.
Okay, sir.
So what will be the management, the ideal management? It's maybe T4A, T4B confusion is there. The patient has measurement and severe trismus, cannot open the mouth. What is the ideal management you feel? And very close to the mandible. Mandible is probably infiltrated also in this case.
Yes, the patient having a metastatic, must do the metastatic.
No metastasis, no metastasis.
Go with the radiotherapy and follow the surgery.
Radiotherapy, I don't know. I don't think. See, the management, actually, the oral cavity management, nowadays, the principle of management is, as far as possible, single modality treatment. That is the idea, as far as possible. Then, what you're talking about chemoradiation. Chemoradiation is not, in this case, it's an option, but probably the ideal management will be a chemotherapy, upfront chemotherapy. Then try to downstage the tumor, reassess the tumor again. Reassess. Okay. If the patient recovers enough adequately and with a good performance status is there, then you can probably think about surgery next, because bone involvement is there. So radiation will not be a good option. Okay. So then if patient recovers adequately or completely or partially, the tumor is regressed, then you can think about next modality, that is surgery will be next modality, because tumor is close to the bone. Then after surgery, you may think about a radiation.
Okay.
That will be the ideal management, because radiation, if you give upfront in this patient, it will produce osteonecrosis. But in a desperate situation, for example, the patient is not at all fit for surgery, nothing can be done, then chemoradiation is an option, because we are not going to contemplate surgery in this patient. Then chemoradiation, you are not bothered about the osteoradionecrosis. If the performance status is good, give chemo with cisplatin or carboplatin-based chemotherapy. Reassess the patient, downstage it, surgical. What surgery you will do? Suppose the patient is come down after chemo, patient is recovered adequately, the tumor has come down in size, patient can open the mouth, there is no retromolar triangular infiltration, and the masticator space was normal. Okay, so what do you do next in this patient? Mandible, it's doubtful infiltration is there in the mid part of the mandible. What is the treatment, surgical treatment? Can you hear me, Rakesh? This connection is very.
Are you there, Rakesh?
And proceed with the compulsory section with the
Sir, I
level-
think signal.
neck node
Yeah,
dissection.
he's okay.
Yes, sir.
Hey, Rakesh, did you hear us?
Yes, sir, now can hear you, sir.
Okay, after chemotherapy, suppose patient recovers, what will you do? What type of treatment do you will offer the patient? That's the question. Chemotherapy will be a better option upfront. Then after chemotherapy, if patient recovers, what will you do?
Okay.
Surgical option.
Yes, I will proceed with the composite dissection, sir. Composite
What?
dissection with the neck node dissection.
What do you mean by composite resection?
Composite dissection of the primary lesion along with the segment of the lower alveolar along with the mandible, sir.
Lower
Yes.
alveolar of the mandible.
In this
That-
patient, sir, the
What is
alveolar
commando's operation?
Sir,
What is commando's operation?
yes, sir. Combined yes, sir. Combined resection with neck node dissection, sir.
Combined mandibulectomy and neck node dissection.
Yes, sir.
You want to say, so you will do a marginal mandibulectomy, is it?
No,
or
sir, no,
segment-
mandibulectomy, sir.
What mandibulectomy? Segmental mandibulectomy, hemimandibulectomy, what do you do?
Hemimandibulectomy, sir.
What is hemimandibulectomy?
Removing one side of the mandible from the incisor up to the TMG.
Incisor up to the?
Temporomandibular joint, sir. Disarticulation from the temporomandibular.
Yeah, you remove the one half of the mandible. Okay, why you want to do that in this case? You may require, I'm not questioning that. You may need to do that because you will have to assess properly. CT scan, if it's showing in the. So, what are the indications for marginal mandibulectomy? What are the contraindications for doing marginal mandibulectomy? What is marginal mandibulectomy? What do you mean by marginal mandibulectomy? Have you heard of the term marginal mandibulectomy?
Yes, sir. Yes, sir.
Yeah.
Leaving 2 centimeter of the cortical bone.
No, 2 centimeters is too much of asking. 1 centimeter, 2 centimeter means that no mandible will have a 2 centimeter margin after resection. 1 centimeter.
1 centimeter of the mandible.
This patient, will you do a marginal or if you have to do a segmental?
We'll do a segmental mandibulectomy, sir.
I was asking what is marginal. You let him. What is marginal? So you will shave only one cortex. Basically, the inner cortex only will be removed, retaining the outer cortex with 1 centimeter margin, isn't it? What are the types of marginal mandibulectomy? Have you heard? You know? Okay, I will tell you. There's horizontal, there's vertical, there's oblique. Depending on the line of resection, it can be classified into horizontal, vertical, and oblique. Okay. And what are the indications for marginal mandibulectomy? That will explain sir's question also, answer sir's question also.
In the lesion involve only the cortex.
Yeah.
Only the cortex.
Outer cortex or
outer
periosteum only. If it is involving deep into the cortical bone, it is a contraindication. Any other contraindication? Large perimandibular lesion. Very large perimandibular lesion. Edentulous patients. Edentulous patients will have a very thin, the mandible will shrink and produce edentulous patient. Okay. So these are the people we don't consider marginal mandibulectomy. And these are the indications for doing either a segmental or hemimandibulectomy. What is mean by segmental
Why don't you
mandibulectomy?
do a segmental mandibulectomy in the edentulous patient? What is the reason for that? You know, when you're doing the marginal mandibulectomy, which space can open? Any nerve in that area?
Yes, the mandibular nerve will be exposed.
No.
Which
Running in
mandibular
the
nerve?
groove. Running in the groove, Joanne.
Yes, sir.
Inferior alveolar nerve. Joanne.
Inferior.
So if you do that, you can open that and the patient will have the persistent neurological problem. Okay, the patient will have persistent pain with the area.
Okay. So that is segmental, means one segment of the mandible will be removed. Marginal mandibulectomy, only one margin will be removed. Okay. And hemi means half of the mandible will be removed. Okay. What is the problem with hemimandibulectomy? Why don't you consider hemi, or what is the advantage of marginal mandibulectomy over hemimandibulectomy? What is the comorbidity you will create by hemimandibulectomy?
There will be a loss of contour, since we have to do some.
Yeah. Complete one face will collapse, isn't it? There is no support for the face, and also you can't put any prosthesis also. Where will you fix the prosthesis? You have already dislocated the entire TM joint, and there's nothing. So patient will have a collapse. The tongue will fall back. There's no support. So if possible, do a segmental mandibulectomy. So one segment of mandible is remaining. If you want to reconstruct it, is easy, and the defect you create is less. Morbidity will be much less, provided you can get good oncological clearance. Always segmental mandibulectomy is preferred over hemimandibulectomy. But in this case, as you
Most
mentioned,
of the time in hemimandibulectomy, you preserve that area of the TM joint. And you preserve the upper
that
part,
is the reason.
ascending ramus of that you preserve, so that you can do the reconstruction of that.
That is one modification we have to do, because otherwise the entire face will collapse. You can't fix any processes. Okay. Okay, so you will do a wide local excision. What is the treatment of oral cavity malignancy?
Treatment it's a T1, sir. It's a wide local excision.
What excision?
T1, sir.
Wide local excision.
Yes, sir.
Okay. What is the margin you need?
2 centimeters, sir.
2. Even 1 centimeter is enough. 5 millimeter pathological clearance and 1 centimeter surgical clearance is enough. 5 millimeter. Anything more than 5 millimeters considered as good clearance. Okay. Less than 5 millimeter and up 1 to 5 millimeters is called close margin.
Close margin.
Anything less than 1 millimeter or involved margin is called margin involved. Okay, so you should try to achieve more than 5 millimeter pathological clearance. That is the standard for oral malignancy. You can divide excision. In this case, it may amount to removing the entire cheek. So the cheek is a full thickness. No skin is not involved, obviously, but we may end up by removing the entire cheek. Maybe segmental or hemimandibulectomy or some marginal mandibulectomy. And neck, what do you do?
Neck, supramolar dissection.
I said the node was positive. Initially, when the FNAC was done, I said this commercial carcinoma.
You do a modified radical dissections, removing of level 1 to 5 lymph nodes.
Okay. So when you remember, whenever in oral head and neck malignancy, the node 1 is any node is positive, the only treatment is MRD, ND, modified radical neck dissection. There is no lesser dissection. Okay. Suppose the node is negative in this case, in oral cavity buccal mucosa malignancy, node was negative. Node is that's only reactive node. No under scrutiny of CT or ultrasound, no other node is found. That means N0 neck. What will be your treatment?
Prophylactic node dissection be done, sir.
Okay. What are the levels you dissect in
levels? 1, 2, and 3, sir.
1, 2, 3, yes. Suppose a tongue malignancy, what are the prophylactic nodes you remove?
Yes.
Suppose there's a tongue with the same features, there's no node clinically.
sir.
Rakesh, you
Sir?
sit in a place with some better connectivity. You are,
Sorry,
you know.
sorry.
Yeah, tell me, what are the levels you dissect in prophylactic neck dissection with the tongue is leaking?
You see a tongue 1, 2, 3, and 4, sir.
Why
External
4? Very good. You said 4 also. Why 4 is also
Yes,
included
there will
in
be
tongue?
a skip metastasis in tongue.
Excellent. Yeah, there is a chance of skip metastasis, isn't it? The tongue can have a skip metastasis to level 4. So always you include level 4. So what is the criteria to decide whether you need a prophylactic neck dissection in an oral malignancy? What are the criteria you to decide whether you need a prophylactic neck dissection?
Yes, sir. T1 disease with no normal, sir.
No T1, T3, no. What? When will you decide? Okay, this patient we will go for a prophylactic neck dissection. See, the one biggest criteria when there's more than 20% chance of the node getting occurrently involved, more than 20% of chance. Okay, by this standard, only very few tumors are there where there is less than 20% chance of a nodes being occurrently involved. Okay, these are the gingival margin T1 lesion, buccal mucosa T1 lesion, and hard palate T1 lesion. All of the tumor and also the tumor invasion, the depth of invasion more than 4 millimeter is an indication that that node will be occultly involved, even if it's clinically negative. Okay, so depth of invasion more than 4 millimeter and chance of a node involvement more than 20%. By this standard, most of the oral cavity malignancy will be having a chance of metastasis to the involved node. So in almost all cases,
will you go for the unilateral or bilateral neck in the tongue or floor of mouth? Prophylactic, will you do unilateral or bilateral?
Go for bilateral only, sir.
In this case, you will do bilateral. Why?
No, this case you go for unilateral only, sir.
Yeah, in this case, because of buccal mucosa, there is no bilateral representation, isn't it? We mentioned what are the areas where you get bilateral representation of the nodes?
Floor of the mouth, posterior
one-third of tongue, or midline, crossing any tongue lesion crossing the midline, you will have bilateral. So, bilateral is a must. In this case, actually, it's only one side, buccal mucosa involved. Buccal mucosa is generally unilateral only nodes. So, if it is node negative, unilateral prophylactic neck dissection, 1, 2, 3. But if node is positive, MRND. There is no. Okay, there is no compromise. Can you tell us one head and neck malignancy? Even if a node is positive, still you can go for a selective neck dissection. Maybe there's only one malignancy in the head and neck region. Even if the node is positive, still you will go for a selective neck dissection, which is a malignancy.
Lip, sir.
No. Oral cavity, lip, one node is positive, MRND. There's nothing else. It is any other malignancy. Can you think about if the node is positive, still you may go for a selective neck dissection. Not in the oral cavity. Head and neck, I said. Papillary carcinoma thyroid. What is the malignancy? What is the treatment of papillary carcinoma thyroid if the node is involved? Which are the level of nodes you dissect?
3, 4, 2, 3, 4.
2A, 3, 4, 5B. Hey, these are the nodes. Or some can say 2, 3, 4, 5, 6 also. 1A and 1B are not dissected. So it's not MRND. Even if the node is positive, you can still go ahead with a selective neck dissection. There's only head and neck malignancy where you do selective neck dissection if the node is positive. Otherwise, all the others where you get a node positive, MRND. There's no confusion. Node is not neck positive. Most of the oral malignancies, you have to do a selective neck dissection because, that is a standard protocol because more than 20% chance is there. Most of the malignancy and tumor thickness is also very important, or tumor thickness or depth of invasion. How will you assess the depth of invasion? Clinically and radiologically, you already mentioned. Pathologically is a must. Is there any situation pathologically the pathologist will find it difficult to assess the depth of invasion?
If it did any previous incision biopsy or
No. You see, sometimes what happens, the tumor will destroy the lamina propria. See, you want to measure the length from depth from the lamina propria, isn't it? Sometimes the tumor will invade through the lamina propria. There is no lamina propria. So how do you know whether there is a lamina propria? So in such situation, you will have to take depth of tumor thickness as the marker for the invasion. Depth of invasion will be a difficult task to assess. Okay.
Okay, sir.
So after you have done the excision of the wide excision, how you are going to repair that?
Reconstruction.
Reconstruction done with three flaps, sir. PMMC flaps, sir. Pectoralis major myocutaneous flaps can be used for this.
So you will give both the cover and the lining with that. You know, you have to always give lining, support, and the cover. The cover is the skin, lining is the mucosa, and support is the bone. You can provide both the things by that. In this patient, if you have done a 1 centimeter wide excision of that,
okay.
So the skin loss is there, there is a mucosa loss is there. And if you
Muscle,
have the
everything is
mandibulectomy,
all
mandibulectomy,
bone
then
is also
the
gone.
support loss is also there. So what is the best one you can go for the reconstruction?
Yeah. Myocutaneous fibula flaps.
I think the pre-flap should be the best, okay?
Yes.
Okay. From where you would take the pre-flap? From the
Radial.
radial.
Radial form.
So where you can have the good puddle of that along with the bone support of.
So the flaps will depend on the amount of tissue loss, how much defect you created. Okay, this is the case. So obviously, large defect will be created in this particular patient. The small defect you can even do have a local flaps, like a transfer of the buccal pad of fat or buccal musculature, all this. But that's only possible in very small defects. Or you can have pedicle flaps, as you mentioned, PMMC or nasolabial flap. All these are possible. Nasolabial only when the small defect is there, one can do that.
Okay.
Then the other option are free flaps, as sir mentioned, the radial forearm flap, lateral thigh flaps, and all those things. Okay. So you have to consider that aspect also once before you do a surgery. You have to consider the. You mentioned chemoradiation. Yeah, sir. Continue.
Can you use the tongue? Can you use the tongue for the lining?
Sir?
Can you use the tongue for the lining? Yeah, that is also a possibility, you know, if we say not a big defect. So for the lining purpose, you can take the tongue, flap from the tongue. And for the cover, you take it from like pectoralis myocutaneous or deltopectoral flap here. You can take that.
You earlier you mentioned about chemoradiation. What are the indications for chemoradiation?
Sir, another?
Chemoradiation.
Yes, sir.
What are the indications?
So local advanced disease, sir, first.
Can you be more specific? It is if you know lymph node is showing extranodal extension,
okay, sir,
or the margins become positive. These are the only two indications of chemoradiation. Okay, we concomitant radiation and chemotherapy. But margin positive, the first option will be resurgery. If resurgery is not possible, chemoradiation. These are the two main indications for chemoradiation. Don't rampantly mention chemoradiation. Chemoradiation is not done in every case. Okay, you can in this case use downstage with chemotherapy only, then go for surgery, then radiation we consider later. Okay. Chemoradiation can be considered if margin is positive. After surgery, margin is positive, you can try chemoradiation. Or ENE, extranodal extension, is an indication for chemoradiation. These are the only two indications for chemoradiation. You give either cisplatin or carboplatin as a sensitizing agent in between the radiation. So it sensitizes the patient for radiation. So the effect will be double. Okay. That is why chemoradiation is principle. To sensitize the patient more for radiation, chemotherapy also will act. Patient will have double effect. So very advanced lesions like this, it may be effective. Then also maybe patient is not fit for any procedure. Yes, you may consider that. Okay, so just chemoradiation. Okay, so the main indication, these are the only two.
Rakesh, what are the various incisions for the modified radical neck dissection?
And collar incision, sir.
Hmm?
And utilitarian incision, sir.
Which did you say?
Sir, collar incision, sir.
All
Okay.
of incision.
So single incision.
Sir,
What is Kreis incision?
sir, could you listen?
What is Kreis incision? Hayes Martin incision?
McPhee.
McPhee. Two flap technique, three flap technique, four flap technique. Okay, tell what are the various complications of the lymph node dissection, block dissection?
Facial edema will be there, sir. Perioperative edema will be there, sir.
Okay.
Perioperative
What is the
edema.
most dreaded complication of the lymph node dissection? MRND?
Carotid artery injury, sir.
Injury or blowout, isn't it?
Blowout.
Yes, sir.
How will you prevent that? So if you are doing a classical radical neck dissection, where you have removed also sternocleidomastoid, can you bring there any muscle to cover the carotid vessels which are exposed? Like if you're doing an inguinal block dissection, do you know any muscle which is there in the inguinal block dissection to cover the femoral vessels to prevent the femoral blowout? Sartorius, you know? In the inguinal, it is a sartorius muscle. And here in the neck, is the levator scapulae. You bring the levator scapulae from the back to cover the carotid vessels. So that is one way to cover that. And second is that you should always have to prevent the flap necrosis, which lead to the infection and ultimately there the carotid blowout will be there. Okay.
As sir mentioned, the principles to prevent a blowout are the one, you try to prevent the flap necrosis. Two, you try to avoid the confluence of inflame in the incisions. So they may be to the at the area of the carotid, so that the flap necrosis is more at the confluence inflame. And then whenever the muscle, the artery is exposed, try to cover it with some transplaced muscle, so that even if this flap gets necrosed, otherwise, once the flap is gone, the artery will be exposed. It can undergo blowout. It will be catastrophic, isn't it? So, what are the modified radical neck dissection 1, 2, 3? You know.
In MRND one, spinal axis will be preserved, sir.
Yes. Okay. Number 2. So,
Number 2, spinal axis now along with the internal jugular will be
preserved. Okay. In 3, all 3 will be.
All 3 will be preserved.
Which is the most important structure you have to preserve among these 3?
Spinal axis, sir.
Yeah. Why? What is the what will happen if you injure the spinal axis now?
Supplying the trapezius, so there will be difficulty in moving the shoulders.
Frozen shoulder and mobility of the shoulder will be affected. So that even if you ligate one internal jugular vein, the other one is okay, nothing will happen. Okay, no, generally sometimes you will have to ligate, but most morbid thing will be the spinal accessory. You have to preserve it somehow. Okay, whatever. That's the most important structure in MRND. You have to preserve. Okay. What are the non-lymphatic structures that you remove in MRND? Non-lymphatic structures in the neck.
Non-lymphatic structures.
What are the lymph nodes you remove?
Level 1 to 5, sir. Submental.
Okay, level 1 to 5 nodes agree. What are the non-lymphatic structures?
Submandibular gland will be removed, sir.
Okay.
And some will be removed. Sternocleidomastoid mastoid will be removed, sir.
Yeah, these three structures may be removed or may not be removed, or as you mentioned. Then the tail of the parotid may be removed also. Sometimes it comes down into the area. Okay. Then all the fibrofat superficial nerve plexus of the cervical superficial nerve cervical plexus may be removed. All fibrofatty tissue in the neck. Okay, all these are removed and blocked. That is the MRND. And as sir mentioned, you remove the sternomastoid, you have to take adequate precaution to cover the carotid by the levator scapular muscle. Otherwise, any flap necrosis will produce a catastrophic bleeding. Okay.
Which
Have you heard of
is more on the left side as compared to the right side? You know, if you are doing a bilateral neck dissection, you know any complication which occurs more on the left side and not on the right side?
Yes, sir. Yes, sir. In left side, there might be a thoracic injury may happen.
Yeah. Yes. So what will happen? What complication will there? Thoracic duct injury is there.
Sir?
If the thoracic duct injury is there,
Okay, sir.
what complication will occur?
Okay, sir.
what will be the manifestation and what will be the effect of the injury? That is, that's what says. What will be the manifestation if thoracic duct is injured? How will you detect it?
Lymph will be.
Lymphedema. What?
Oh, sorry.
Chyle will be coming out.
The drain will be more. You know, you put a drain, and the drain will be in many hundreds of mLs. Okay.
Okay, sir.
So it will be node of drain, which is slightly whitish and milky in color. It will keep on pouring out. So what will happen to the patient if there is a lot of lymph leak or chyle leak?
And the third space loss will be there, sir.
Huh?
Third space loss will be there, sir. Patient and
Third space. No, it's contained a lot of nutrients. You know, all the absorbed nodes. So patient will lose weight. A lot of. Okay. So what will you do? Suppose there's a thoracic duct injury is there. What can we do? It is you will have to ligate it. So it's very difficult to find it. So, but if you find or you will have to observe and do some clipping. Otherwise, it will a lot of loss of the chyle will produce a lot of problems. Okay, try to explore and try to avoid it. Especially when you dissect the level 4 node into the deep depth on the left side, as sir mentioned, left side is the problem. So try to avoid a blind dissection and cutting structures not under vision. Try to prevent it. Once it happen, try to ligate or clip it. Okay, that's the best option. So, otherwise, there will be a lot of loss of the chyle. Okay, another injury can happen in the pleura. Sometimes the pleura will come up also. Deep dissection of level 4 pleura can be injured. You can have pneumothorax and all. These are some of the complications of the dissection. Have you heard of liquid biopsy? What is liquid biopsy? Have you heard of the term called liquid biopsy? There is some role in the management or prognostication of the oral malignancy with liquid biopsy. What is liquid biopsy? I think we lost him. See, are you with us, Rakesh?
Yes, sir. Yes, sir. I'm here, sir. Can hear you, sir.
Yeah, liquid biopsy is just examination of the blood only. Blood. In the blood, you check for two things: circulation in tumor cells and circulating tumor DNA. So depending on this, you can prognosticate how the patient is improving, or what are the, even it can be used for screening. Okay, patient in a high risk area, you can screen. These are the developments happening, especially in oral malignancy. Many other malignancies also it's happening. Oral malignancy also, it is very much there. Okay, it's called liquid biopsy. Should know. Any role for sentinel lymph node biopsy? Suppose there is no node in this case. Absolutely nothing. No node. Can you use sentinel node biopsy?
Yes, sir. Maybe the first.
Is there any role in any role in this case or oral malignancy? it is not completely clear in the clinical practice. Some people have started doing, but it's not completely accepted because neck is having a very wide, different way of metastasis spread. Okay, so sentinel node is not yet a practice, a standard of practice. It is coming. Some people have, many papers have come out. People have started doing a sentinel node biopsy by either by injecting dye like the indocyanine green or by the radionuclide technique. Both are people. So just when somebody asks you in the exam, started doing
In which cancer first the sentinel biopsy was done? You know, which cancer where the first time the sentinel biopsy was done? It was in the penile cancer. You know. In the penile cancer, it was done first time. Yeah.
Yeah. Nowadays, people have started doing in carcinoma. Breast is almost definite practice all over the world. Neck oral malignancy, it is not yet a standard of practice. Okay. Okay. So since it is not a tongue malignancy, we just touch upon the tongue, which is more commonly seen discussed. It's tongue malignancy. Okay. Tongue glossectomies and all. We will finish with what are the? Do you know any classification of glossectomy?
Glossectomy. Sir, heavy glossectomy, sir.
No, there is a classification you should read about it. There's Anserin's classification. Is there Anserin classification? It's like mucosectomy, partial glossectomy, hemiglossectomy, subtotal glossectomy, and total glossectomy. Okay, what are the components? You have to see the pictures, and it's available in the article site. If you can search and find out Anserin classification of glossectomy, depending on the area of involvement. And you can decide how much you have to remove the tongue. Okay. So tongue, how many muscles are there in the tongue? Tongue.
It's the intrinsic and extrinsic muscle.
How many intrinsic? How many extrinsic? On each half.
Sir? Please, Neoblasts.
Number. How many intrinsic? How many extrinsic?
So 4, sir.
4 intrinsic and 4 extrinsic muscles on each half. So total 16 muscles, isn't it? Okay. What is the nerve supply of these muscles?
Hypoglossal now, sir.
Hypoglossal. All of them are hypoglossal?
No, sir. Trigeminal nerve.
Trigeminal nerve supplying tongue. No, only one muscle. Palatoglossus is supplied by the vagus nerve. Okay, the pharyngeal plexus of the vagus. Others, all of them are supplied by the. Okay. Right. So, intrinsic muscles are above the. What do you mean the root of the tongue? Have you heard of the terminology called root of the tongue?
Yes, sir.
Root of the tongue is the septum of the tongue attaches to the extrinsic muscle. That's the area where you attach to the extrinsic muscle area is called the root of the tongue. Okay, there's a terminology called root of the tongue. Okay. Sir, anything more want to discuss, sir? Ajay, sir?
Sir, sir, thank you very much. I think you have covered extensively the oral cancer. Sir, normally we allow the students to ask any doubts to be clarified.
Oh, fine.
Rakesh, do you have any doubts to be clarified?
Yes, sir.
Have you studied well? Do you have any doubts or any ambiguities? Or how do you want to face the exam questions? If you have any doubts, you can clarify with the examiners here.
Okay, sir.
So one point, Rakesh, I want to tell you is that when you present a case in the history, whatever you say in the history, there will be questions raised on that. So don't mention anything just casually, and don't expect to get away. Okay, that's why I asked a few deliberate questions to Hosner on some things you asked in the, you don't know why you asked of. That situation should not be there. You should know why you asked. There should be an answer. Okay. Otherwise, you've done well. Okay.
Thank you, sir.
Kanna sir, any other points, sir? Kanna sir?
Yeah. No, I think he has done good. Rakesh has
Yeah.
done good.
So, can we call a close, sir, senior faculty?
Yeah, please. Yeah.
Okay.
Thank you, Rakesh. Thank you for joining. Thank you, Haridas, sir.
Yes,
Thank you
thank
for joining with the short notice. And we also express our thanks to you for spending all the time covering up the entire oral cancer. We look forward for have you in for upcoming classes also, sir.
Sure.
Thank you very much, sir.
Thank you very much, sir.
Okay.
Thank you. Thank you, Rakesh.
Thank you, sir.
Thank you, Kanna, sir. I think Raji Sahay, sir, has left. And friends, we, on behalf of the faculty, wish you all a happy Diwali and Dhanteras for the
Happy
upcoming
Diwali.
festival. Thank you, everyone. And we look forward for yet another class on Friday. Thank you very much. Good night, friends.
Good
Good
night.
night. Good night.
Thank you, sir.
Good night.